Morning everyone. I've had a bit of a panic this morning. Set everything up last night, all the videos working perfectly, plugged them into the system, and then just testing it, and then nothing was working. So I've just had to spend the last 5 minutes uploading everything. So hopefully it all goes smoothly today. Good morning, Martin. Welcome back. Good to see you back. Looks like we've got a few online already. So we're going to do a bit of a recap of last session. We're going to start to have a look at the ligaments around the thoracic spine and the ribs. And let's just have a look at this. Yeah, so we were looking at rib function. Just go back a bit over these, and we were looking at atypical and typical vertebra, and the fact that some of the vertebra in the thoracics, if I go back to that slide actually, that's got all of them on. It's not on that one. That's one of the ones that are missing then. Here we go. Yeah, so 5 of the 12 vertebrae are considered atypical, so T1 and then T9 down to T12. And most apparent differences between the thoracic spine and the remainder of the spine are the 12 ribs and their articulations. So we know that there is a difference with the thoracic spine compared to anywhere else because the ribs attach, but then the ribs attach in different places in each of those, on each of those vertebrae. So yeah, definitely worth having a look back at the previous episode to go over those, and it helps to explain the function of the ribs as well. So some of the ribs come upwards, so they have like a pump handle, what we call a pump handle movement. Some of them come out to the side, so what we call a bucket handle. And then the lower ones then come out kind of horizontally, if you like, in that transverse plane, and they are more pincer. So the idea is, just move that camera down a bit, that all of the rib cage, so from the top, from the sides, and from the bottom, all can expand to give the lungs the maximum amount of space to take in air. So yeah, so that was last week, and then we are on. Where has that gone? Bear with me a sec. Oh, that's what it looked like in real life. Green screen behind. There aren't really. Where's it gone? There we go. Yeah, I've got 2 ligament files. Yeah, there's not really cadavers behind me. It is just a green screen. Morning, Carol. Morning, Tris. Morning, Ellie. Morning, Becky. Right, so we don't want that one. We want this one. Here we go. Okay, so let's go back. So some of this is going to be a little bit of a recap. Because the ligaments of the spine are exactly the same, no matter whether you're looking at the lumbar spine, thoracic spine, or up into the neck. The shape of the vertebra are obviously different, and we've looked at that already. And the shape of the facet joints are different, and obviously the articulation with the ribs, with the thoracic spine. But the ligaments remain the same all the way through, and they're continuous. Yeah, so from the sacrum all the way up to the base of the skull. So let's just do a quick recap on those. So one of them, just get rid of that. There we go. So one of them is called the ligamentum flavum. If we get a bit of an orientation of where this is taken from a book called The Trail Guide to the Body, and they've got some really good images of this kind of stuff. So I use this quite a lot with my teaching. So here is a view of a superior view of a vertebra. This one looks like a lumbar vertebra, but again, it doesn't matter, the ligaments are the same. So you've got the vertebral body here, and then what they've done is they've taken a section through the pedicles. Where, again, we've been talking about this over the last couple of weeks, so have a look over the previous episodes if you're not sure what they are. And then the view that we've got is the direction of this arrow. So we're looking towards the back of the vertebra from the inside, okay? And that's the view we've got here. So there is a cut pedicle, and then this area here is the lamina, which is that area there, okay? So obviously the spinal cord, if this was a real body, would be in front of these ligaments, okay? So there'll be the spinal cord here, but obviously that's been taken out of the picture so that we can see the ligaments behind. And then these are the ligamentum flavum. So they attach to the lamina and onto the pedicles as well somewhat, of the vertebra above and below. So if we think about what they will do, is that if you flex your spine, so if you bend forward, those ligaments at the back will become stretched and they'll limit the movement into flexion, okay? Obviously ligaments are there to help provide stability for the joint, so exactly the same as the ligaments in your ankle. There's a role for the ligaments to play in the spine. They have a high amount of proprioceptors, so basically kind of stretch gauges, so they can tell your brain exactly where your spine position is, okay? They can get injured, so ligamentum flavum can get injured, and often in car accidents or something where there is quite a high flexion velocity, okay? So if you have hyperflexion, so like a whiplash type movement, then that can stretch the ligamentum flavum, which can then injure the tissue. And what will then happen is it will repair and it will become hypertrophied. So it will grow in size. Now, if you have a look here, the only way it can grow, or the only space it can grow into, is into the vertebral canal. So that can create a compression over time, it's not going to happen immediately, of the spinal cord. So it is something that is often remarked on when you have an MRI report. So they will, if there is a hypertrophy of the ligamentum flavum, then they'll put it in the notes that there is. Okay, so that's basically what they mean by that statement. So if you've seen that before in an MRI, that's basically what it is. So let's have a look at the ligamentum flavum, hopefully, if I can get these off. Here we go. This should be it. Fingers crossed. Yay, it worked. Thank God for that. These were all blank about 10 minutes ago. Okay, so yeah, ligamentum flavum then. So this is obviously on a dissection now. So we'll have a look at this image in a sec, because this has got all of the ligaments of the spine on. But the bit we're interested in is this bit at the back here. So that's what we've just seen, okay, that ligamentum flavum that's connecting the lamina, okay? So there's your vertebral foramen. That's where your spinal cord will go down. You've got your vertebral bodies in the front, transverse processes at the side, facet joints around here. So this is the line that they're going to cut, so down the pedicles, there we go. And we're going to flip around and then have a look at the lamina. Okay, so there's an end of a pedicle, and then there's your ligamentum flavum. Okay, so that's what it looks like in real life. So you can see how it, obviously in the pictures, it's, you know, nice and stripy, and yeah, it just looks like a blob, okay, of collagenous tissue. Okay, so the reason why it's called ligamentum flavum is because of the colour, because it is a yellowy colour, and that's where the word flavum comes from. So it is a yellow ligament, and it is continuous down to the sacrum all the way up to the base of the skull. Okay. And that's basically what it looks like. So you can see that if that does get flexed, it's going to stretch that ligament. And if it's hyperflexed, then you can have an injury to it, just like any other ligament in the body. Okay. So that's the first one. That was the picture that was just on the video. So ligamentum flavum is just here. Okay. So that's what we've just seen. So then the other ligaments that we've got longitudinal ligaments. So they're really long, okay, and we've got two of those. We've got this one here, which is anterior longitudinal ligament, and then this one here, which is posterior longitudinal ligament. So we've got one at the front and one at the back. They don't just divide in half as they come around the sides of the vertebra. They're continuous, so they wrap all the way around the vertebra, and basically, yeah, they've just been divided into posterior and anterior, but they're kind of continuous. The shape of the posterior longitudinal ligament is a little bit different. I've got it there. I'll show you on the video, because it runs all the way down the back of the vertebral body, and obviously we've got the disc in this position as well. And we were talking about herniations a couple of weeks ago. And one of the reasons why a disc doesn't usually herniate centrally, is because of this ligament at the back, the posterior longitudinal ligament. Okay, so yeah, we'll have a look at the shape of that now. So let's get on to that one. So this is the posterior, hopefully. Yep. So posterior longitudinal ligament on the back of the vertebral body. All right, so we'll have an orientation in a second again. So there's your vertebral body, spinous processes, and we're going to be looking at the back of it, so the posterior aspect. Okay, so they're going to cut down this pedicle line again, but instead of having a look at the back of the vertebra, we're going to have a look at the back of the vertebral body. So there's the ends of the pedicles again, and then there's your posterior longitudinal. So if I just pause that there, so you can see it's running down the center in between the pedicles, and then there's a disc just there, and it's attached to the disc. So like I said before, this is the reason why discs don't tend to herniate centrally, because there's this whacking great big ligament in the way. So we've got a really good protection there for the spinal cord, which will literally just be directly behind this. Okay, so if you imagine what's been removed, your spinal cord would be here, in front of this ligament. The ligament does extend laterally, but if you can see here, there's kind of like a gap around this area here. So this is why discs usually herniate posterior, so towards the back, laterally. Okay, so they go to the side and then stick out. So that's why we get a lot of nerve root issues, because that's where the nerves come out as well, rather than central cord compression, which again kind of makes sense, because if you herniate and you squash the cord, you affect everything, both sides. If it herniates and comes out just one side, it's going to affect one side of the body. Okay, so whoever designed this again did a good job of kind of protecting that area really quite well. So that's your posterior longitudinal, and again that's going to stop you from flexing, but you're not going to be able to flex forward and stretch this ligament quite as much as you would the ligamentum flavum, just because the vertebral bodies are in the way. So you're not going to really open up the back unless you have a traumatic injury. So just play that again. So you're going to get a lot more movement of that ligamentum flavum than you are of this posterior longitudinal, just because of the position of it and the forces acting on it. Okay, so there, yeah, you can see the discs in between the vertebra. So there's one there, there's one there. There you go, cool. So that is that one at the back. Okay, so we've done that one, that's your ligamentum flavum. We've done that one, that's the posterior longitudinal. And then this one at the front is the anterior longitudinal. So this is the one that helps to prevent hyperextension. Okay, so all of the others so far, so posterior longitudinal, ligamentum flavum, they have prevented flexion. This front one stops you extending too much. Okay, and again, it provides stability to that vertebral column. So let's have a look at that one. Just get rid of those. Here we go. So this is the anterior longitudinal, so the one at the front and the one that's long. And here we go. Okay, so again, it's not as pretty as it looks in the books. Okay, so you can see, oh yeah, looks you know, you can easily tell what it is, but obviously they've removed a lot of other soft tissue around this area, but the shape of it is it basically adapted so that no anterior longitudinal ligament will ever look the same in any other body. The ligaments will adapt to what you do throughout your life, just as if they in every other part of your body as well. So the orientation of these and the look of these will be different in absolutely everybody, but the direction of travel and where they are will be the same. They'll just they just won't be exactly the same. So your vertebral discs are here, vertebral body is underneath here. So this is looking at the front of your vertebra. Okay, so the anterior aspect of the vertebral body. There's your transverse process out the side. And like I said before, there's not this clear line. I mean, there is now because they've dissected it, but in the real life, there isn't a clear line. Yeah. So, I mean, that is just a phenomenal dissection to be able to take that away as cleanly as that. That must have taken hours. So we've got attachment to the vertebral body in the discs at the front, and then it comes all the way around as well to this neural or intervertebral foramen round the side, and then merges into the posterior longitudinal ligament around the back. Okay, so obviously they've taken that bit away just so you can see the vertebra underneath. But there you go. So that's the movement it limits, is hyperextension, to protect, again, just to protect the spinal joints. So yeah, this is probably the best one just before they remove everything. So you can see how it's continuous, yeah, all the way around. And then it's around that point, there you go, then that's when they take the rest of the tissue away, so you can see underneath, yeah, see the relationship between the structures. So it's not just floating, this is like this is attached to all of the front of your spine. Okay, cool. So we have done ligamentum flavum, so we're attaching lamina to lamina, so the lamina above to the lamina below. We've done posterior longitudinal, which is on the back of the vertebral bodies, so the posterior aspect of the vertebral bodies. Now we've just had a look at the anterior longitudinal, so that's on the front of the vertebral bodies. The last one is this one in here. We have got the supraspinous, well, they're kind of two joined together. So we've got the supraspinous ligament, which means superior to the spine. Okay, so this bit here is a spinous process, that one there, and this ligament runs all the way down those spinous processes. So when you feel down someone's back, the layers would be skin layer, superficial fascia, bit of fatty tissue, and then supraspinous ligament. Okay, so even though you can palpate quite easily the spinous processes, there are layers of tissue in between your skin or the client's skin, and then getting down to that bone layer. Okay, so you'll be basically palpating the supraspinous ligament as well as all the other structures. And then this one here, this is the interspinous ligament. This is in between the spinous processes. So interspinous, in between the spinous processes. And again, if you have a look at the direction of those, they are going to prevent flexion. Okay, as well the supraspinous ligament. So we've got supraspinous, interspinous, ligamentum flavum, posterior longitudinal, all acting to limit flexion of the spine. Okay, so all of those do that. And then the anterior longitudinal is the only one that limits hyperextension. Okay, well, I should say hyperflexion rather than just flexion. Okay, so yeah, we've got 1, 2, 3, 4 stopping you hyperflexing, and then the 1 stopping you hyperextending. Okay, so let's have a look at interspinous. Here we go. So both interspinous and supraspinous ligaments. Just move me out of the way again. Okay, so there's your interspinous. In fact, let me just, that was a really cool kind of like reveal. So there's the space, and then ta-da, there they are there. Okay, so they're only quite small. Well, obviously they're going to be, because well, it depends on the space in between the spinous processes, how big they're going to be. But that's an interspinous ligament there. It looks, yeah, there's the anterior longitudinal just at the front, and then there's your supraspinous just there. Okay, so you can see it attaching onto the very end of your spinous process, just there. So supraspinous, interspinous, just there. So that's what they look like. It's pretty thick, that supraspinous ligament. It's quite surprising how thick that one is actually. Cool. So that image there is basically, just pull that there. Yeah, so that image there is basically that one from the book, okay? But obviously this is the real life version, and then that's the cleaned up version that looks nice and pretty, okay? So you are missing some ligaments here. So the part of the anterior longitudinal ligament is missing around here, so it does look a lot cleaner than it would be. And obviously all the muscles are gone as well. There's no muscles on this picture. So there's a lot more going on in this area than what you see even in this image. But that is a really good dissection to show the individual kind of ligamentous structures. Cool. So that's that. Okay, all of those ligaments there, and it's exactly, I mean, that the images you've just seen are more lumbar spine, but it's exactly the same in the thoracics as well. The bit that's different in the thoracics is this. Okay, so we've got radiate ligaments in the ribs. So here's your facet joints for the ribs to attach onto the vertebral bodies. Yeah, so we've got these demi facets, like half facets, and then there are ligaments that attach the ribs onto the thoracic vertebra. So the superior ligament ascends and is connected with the body of the vertebra above. So we've got that bit radiating out that way, okay? The inferior ligament descends to the body of the vertebra below. So we've got that one going that way. And then the middle ligament, the smallest and least distinct, is horizontal and it attaches to the intervertebral disc. So that bit goes that way, okay? Hence radiate, like sunbeams, it's radiating out and then attaching onto the vertebra, okay? Then the only other one we've got, and I'll show you a video of these in a sec, just move me out of the way there, is this one. Now you should be able to hopefully work out the name for this, but based on what it's called. So we've got, that should be transverse rather than transverse. So costo-transverse ligaments. So it's going from the costos, which are the ribs, to the transverse processes. Okay, so there's your rib. So attaching from there onto the transverse process. And again, we've got superior ligament, inferior, and then, oh no, that's not right. That's not right. Sorry. That's been copy and pasted from the last slide. It doesn't go that. I was thinking that. It basically goes from your ribs onto the transverse process, and that is it, okay? So costo-transverse from the rib to the transverse process. Apologies. Trying to cut corners. Terrible. Right, let's have a look. Have I got the rib ligament? Where's that gone? Bear with me a second. Let me just grab that. away. Yeah, this one's a really nice one, so I want to show you this one. Ligaments, ribs, here we go. Pop that on there. Okay, let me just make this bigger there we go. Pop that in the middle. Okay, cool. So these are the ligaments that we were just talking about, the radiate ligaments. So there's your rib, there's your vertebral body, and then there's the radiate ligaments there. Okay, so you've got the superior, middle, inferior, and then there's your costotransverse. Okay, that was really quick. I'm going to have to slow that video down a bit. Okay, there we go again. So radiate ligaments all around here, and then there's the costotransverse one there. Well, that's a superior one. Okay, and if I just pause that there. So we've got superior, higher, okay, costo, ribs, transverse, side, okay. So it will go from the rib below up onto the transverse process of the one above, and to the side, okay. So yeah, those are your two ligaments that are around the attachment point for the ribs. And I think I mentioned it a couple of weeks ago. Let me just move on to that one. Where's that gone now? Bear with me a second. Yeah, the people being able to palpate the rib heads, and they're so deep, and being able to ascertain whether a rib is moving or not. You've got absolutely no chance of that. Bear with me a second. I'm just trying to find the right one. Here we go. It's that one. There we go. Cool. We're back. So now we've done the ligaments, got those done. We'll have a look at the muscles of respiration, and then the other muscles of the thorax. So we'll do the muscles of respiration first, and then we'll add on the other ones. The good thing is with the thorax, we cover probably one of my favourite topics, which is the heart and the circulatory system. So we'll do a whole session on the heart. Love that, because obviously we cover the blood supply and nerve supply for everything, and what better blood supply than having a look at the heart. So a muscle that everybody seems to be obsessed with, the diaphragm. We're going to have a real good look at this one. So we've got it's a kind of a separation between the chest cavity and then the abdominal cavity, and the separation is the diaphragm. But there are tubes that need to get from the top part of your body down to the bottom part of your body, and then back up again as well. So it has to have holes in, but it needs to be fairly solid. So you might have heard of clients having things like a hernia. And it's where some of the abdominal contents have come up through the diaphragm into the space above, into the chest cavity. So we'll have a look at where that occurs, okay? And yet when you see it, it's like, oh, right, okay, it makes sense that that would happen. Obviously, it's not common in younger people. It's usually as you get a bit older, or especially if you're carrying a bit of weight as well, and you've got lots of visceral fat. Yeah, you can see why you would have those herniations, because of the you have to get the tubes through, okay? So, but the main function of the diaphragm is obviously breathing. So when you contract the diaphragm, it drops down, and then it draws air into the lungs, and then all of the ribs move all at the same time. So we were talking about the pump, the bucket handle, and the pincers. All of that is going on whilst your diaphragm is descending, so that we can draw air into the lungs. Okay, so all of that is happening all at the same time. So we're going to have a look at the muscles involved in that mechanism, hopefully. Just pause that on there. Let's... oh, good. Okay, so, yes. This is a view underneath the ribs, Okay, so we've removed all the abdominal contents. Sorry, just pop that there. Just lock that in place. There we go. So here's the edge of your ribs, just here. Okay, so that's what we've been looking at over the past couple of weeks. There's your vertebra from the lumbar spine, and then these will be the ribs, the lower ribs, 11 and 12, the pincer ones. So now we've got the diaphragm in place, which is all this area here. Okay, so it's like a big dome that fills that kind of chest cavity space and attaches all around the ribs, and then obviously onto the vertebra at the back. But can you see these holes here? So every hole is there for the different vessels or tubes that are either ascending or descending. So obviously the heart needs to be able to get blood from the heart to your legs, and the diaphragm's there, so you need a hole for the descending aorta to go through. Okay, but then once that oxygen's been used in the legs and it's coming back up, you need a hole for the inferior vena cava to come up through as well. Then we also need to eat. So we obviously, food goes in our mouth, travels down, and then it's got to get into the stomach somehow. So we need a hole for that as well. Okay, so we've got all these different openings for different tubes that are either traveling up or traveling down. So let's have a look at that. Hopefully, here we go. Okay, so there's your vena cava foramen. So that's where the blood supply will come back up. Just pause that there. There's your esophageal hiatus. So that's your food tube. And then, let's just go back a sec. Oh, none of my blooming controls are working on this. It's so frustrating today. Right, let me just lock that. Yeah, I've got, you won't be able to see it on yours, but I've got so many play buttons from all the different videos. Let's go back there. Is that going to work? No, that's the wrong one. Bear with me a sec. Let me play that again. Yeah, and then we've got this crura or cross of the diaphragm where it crosses over, and you've got to create tension around the tubes that are coming up and down. So obviously it minimises the risk of contents either going up basically into those spaces. You've got the arcuate ligament in the middle there, again providing stability around these openings for the tubes that are coming through. Right, let me just play that again. Here we go. Okay, so vena cava coming up through there. There's your esophageal hiatus. Okay, so that's coming down into your the tube down into your stomach. So you got another video in the background now. And then the crura of the diaphragm, and then I think the last one that you just saw there was the aortic opening as well. There we go. So that area there is obviously really, really important to the function of your body as a whole. But it's this area here and around the sides that contracts and relaxes so that we can breathe. So we've got all of that going on at the same time. We've got that structure in the middle trying to maintain the integrity there. And then all around the outside, we've got the contraction and relaxation of the diaphragm. So a really nice view. We'll just get rid of that one, bring this one in. Hopefully, it's working on this one. Okay, so this is going to be a view now of the top of the diaphragm. So they're going to remove the sternum, remove the ribs, so that you can see the top. Here we go. So there's the domes of the diaphragm just there. There's your thoracic vertebra at the back. Another dome just there, and then the ribs coming around the side. So you can see that they've removed the sternum as well, and then you can see the top of the diaphragm just here and here. So when that contracts, obviously that comes down, and then that helps to create a negative pressure, which then draws air into the lungs. we'll have a look at the nervous system and everything that's around there on subsequent sessions. But yeah, there's the dome of your diaphragm at the top. So obviously your lungs will sit on top of those just here. That's pretty cool. And then we've got, last bit is this one here. So this is the undersurface of the diaphragm, but then with some other areas attached as well. So you might recognize some of these muscles. You might recognize that one. So that's your psoas. Might recognize that one there. Looks like your QL by the look of it, because it's attaching to the iliac crest and coming up into the ribs. So these are really, really deep muscles, okay, because there's your vertebra just there. Okay, so again, I mean, we were talking about this on the weekend. I was teaching yesterday. We're talking about being able to palpate the psoas, and what's missing from this picture as well is all of the organs on top of this this area here. So you've got your small intestines. You'll have the liver up here. You have the kidneys at the back. You have your large intestine all the way around as well. Okay, so there is a lot of stuff in front of these structures that you kind of have to fish through if you are going to contact this this muscle right here. Okay, and again, if you've ever been to the labs, you'll know it's virtually impossible. Right, let me just pause. That one seems to, I've started a video in the background. Let's go for this one. Here we go. Okay, so these are all your ribs, intercostal muscles in between. There's your diaphragm that you can see there. And these are the openings that we were just having a look at. Xiphoid process, which we looked at on the last couple of weeks. So yeah, there's your QL. And then there's your diaphragm, like right underneath. So you can see the attachment, that is a central tendon. So it all kind of merges into this central point and wraps around the esophagus and the vena cava and the aorta. But that's what it looks like. Okay, you can see the attachments down here as well onto the lumbar spine. So it's quite a broad attachment for the diaphragm. It kind of wraps around. Well, you'll see in a second, they draw a line on the ribs. So it wraps all the way around the ribs. There we go. So, but onto the back of the xiphoid process, all the way around the ribs here, and then attaching onto the vertebral bodies at the front. Okay, so from that 12th rib onto the vertebral body, which is around this area here. Yeah, there's your QL, there's your psoas, and then there's your vertebral bodies at the front. Okay, so massive, massive muscle, loads of stuff going on as well. And hopefully you can see now why someone might get a hiatus hernia, where they'll get part of the stomach will come up through that esophageal opening and create problems basically. And you might have heard of clients having hiatus hernias, but that's basically what's happening, and you can see the structures just there. Cool. It looks a lot prettier here. Okay, you can see the openings here as well on the picture, which is really good, but it's nothing like seeing it in on a real body. Then we've also got some other muscles. We've got a bit of time, so we'll try and get as many of these done as we can. So we've got external intercostals. There's also internal intercostals, so we'll have a look at those two together. But there are actually 3 sets of intercostals. So you've got external, internal, and then innermost. Okay, you don't usually get to see the innermost intercostal muscles on dissection videos, but they do exist. So we've got three layers of intercostals. So we've got attachment from the inferior border of the rib above to the superior border of the rib below, and the action of the externals is to draw the ribs superiorly. Okay, so it's going to expand the rib cage. So as you breathe in, intercostals will expand the rib cage. The diaphragm will descend, so that your rib cage space is increased, and then you draw air in through the lungs because of the pressure differential created by the diaphragm. Okay, and then there's your internal. So they're orientated in a different direction, and they draw the ribs inferiorly. So if you want to do like forced expiration, so a really big breath outwards, you're going to be using those internal intercostals to help squish the lungs down as much as possible to try and drive that air out of the lungs. Okay, so if you do breath work, that kind of thing, then that will be some of the muscles that you're using. So let's have a look at those. Hopefully, get rid of that. We don't want to see that one again. Here we go. Okay. Intercostals, there we go. So let's go external first. Move that across a little bit. Hopefully the video behind won't play. No, good. Okay, so external intercostals here, so in between the ribs. So external, outside, in between costal ribs, hence the name. We've got oblique fibres. Okay, so that's why we get the movement we do of the rib cage, because the orientation of the fibres, and they attach from the rib tubercles all the way down just before the costal cartilage spaces. I think that's it for that one. Yeah, so we'll have a look at that again. So there's a rib, there's your intercostals in between. These can sometimes get exquisitely painful. I don't know whether you've ever had intercostal muscle pain. Oh my God, it's really, really sore. Had a coughing or a sneezing fit, then you can pull a muscle anyway. You can pull these definitely. Okay, cool. So those are your externals, and then the internals look like this. Just move that over there a little bit. So there's your ribs, taken off the externals, and then these are the internals. So they're underneath, or they're deep to the external intercostals. Slightly more anterior on the ribs and in a different direction, because obviously they're going to draw the ribs down rather than drawing the ribs back up. So again, from the angle of the rib all the way around to the costal spaces in between. And then that's the direction of the fibres, because they're going to work in the opposite direction to the external intercostals. Okay, so externals going to help the ribs expand, and then the internal intercostals are going to help the ribs kind of collapse in, if you like. So then we've got expansion for breathing in, and then the collapsing for breathing out. Okay, and again at the same time, diaphragm working. Okay, and then the only other one, may as well finish this off. A little bit of time. Oh, I did do the innermost, but there isn't a picture on the cadaver, unfortunately. The only other one is your scalenes. Okay, so we've got 3 little muscles in your neck, and we'll cover these a bit more when we get to the cervical spine. But they attach from your neck onto the top of your ribs. And remember, we were talking about the pump handle action of those upper ribs. That's basically what the scalenes do. So they will lift your upper ribs to create space at the top of your rib cage. Okay, so let's have a look at those. Here are your scalenes. Just move that there. Here we go. So we've got the sternum there. There's your first rib, second rib just there. And then these are your scalene muscles. So we've got 3 of them, anterior, middle and posterior. We'll talk about what that is when we get to the shoulder. So we've got anterior scalene attaching onto the first rib just there. So if that muscle contracts, it's going to lift that first rib. The middle scalene attaching onto the first rib, but just a little bit further back. Okay, so that one's just attaching onto there. And then your posterior is going down onto that second rib. Okay, so from the neck onto the second rib, and again we've got that pump handle action of those upper ribs. Because of the shape of the facet joints, the orientation of the joint will allow the ribs to move superiorly, and you remember there was a little join between the manubrium and the sternum, the angle of Louis, and that bent to allow those ribs to come up as well. So that sternum isn't just a straight bit of bone, there's a join in it as well. So you're going to get a lever coming up and those muscles at the top. So we have got, just pop that back on there. So we've got scalenes at the top, lifting those upper ribs, internal, external and innermost intercostals, all working together to either expand or contract the rib cage. And then you've got the diaphragm as well, drawing air into the lungs, and the you know now about the shape of the ribs, the direction of the movement of each of those ribs, and how the muscles then attach onto the ribs to bring about those movements. So that's how we expand our rib cage so we can breathe, and that's how it also contracts back down so we can breathe out. Okay, cool. Quite a lot in today's session. So all of those ligaments and the muscles of respiration. So next week, we're going to have a look at the muscles of the thorax. So the kind of wider global muscles around the rib cage region, and basically anything that attaches onto the thoracic spine. And then once we've done that, we'll start having a look at the blood supply and the nerve supply for the region. And like I said, we'll cover the heart and the circulatory system and the lungs as well. Okay, cool. I will see you next Monday, 10 o'clock. See you then.